starting to talk about the peripheral nervous system, which the peripheral nervous system is the part of the nervous system that extends out from the central nervous system, the brain and spinal cord. So the part of the peripheral nervous system that extends out from the brain are the cranial nerves. And we have 12 cranial nerves. And the key thing to remember about these cranial nerves in terms of what we want to take away from this is that unlike spinal nerves, which are all both motor and sensory in nature, the cranial nerves have a variety of arrangements. So there are some cranial nerves like cranial nerve 1 and 2, the olfactory and optic, that are entirely sensory, okay, conveying both the sense of smell and vision. There are also cranial nerves that are entirely motor, like the 3, 4, and 6, which is the oculomotor, trochlear, and abducens. And then we also have cranial nerves that are a mixture of motor and sensory. Okay? For example, the trigeminal nerve, cranial nerve 5, has several branches that are sensory and some branches that are motor. Okay? And one more thing for us to keep in mind when we're talking about the cranial nerves is that several of the cranial nerves are also autonomic in nature, so they convey autonomic control over the body. And the most important cranial nerve for the parasympathetic nervous system is cranial nerve 10, or the vagus nerve. And we'll talk more about the autonomic nervous system in a moment, but this is the part of our nervous system that controls organ function and involuntary functions, and the parasympathetic nervous system controls baseline function and resting conditions. And the vagus nerve, cranial nerve 10, provides over 70% of the parasympathetic input to the body. So it's a very important cranial nerve for autonomic control. The spinal nerves are the portions of the peripheral nervous system that extend out from the spinal cord. And the spinal nerves come out from the spinal cord. Here we've got the picture of the spinal cord, and we've got the meningeal layers on top of it. And the spinal nerves, all of the spinal nerves with the exception of spinal nerve pair at C1, okay, all of the spinal nerve pairs with the exception of C1 are both motor and sensory in nature. We have 31 pairs of spinal nerves, and they, with the exception of C1, they're all motor and sensory. And so the sensory nerves are conveying information from the body towards the central nervous system. And they enter the spinal cord on the dorsal side, okay, through what we call these dorsal roots. The motor commands that control skeletal muscle and voluntary movement come out of the spinal cord on the ventral side through what we call ventral roots. And the ventral roots and the dorsal roots converge, the motor and sensory fibers converge to form spinal nerves. Okay? As I said, we have 31 pairs of spinal nerves that come out of all the segments along the spinal cord and the vertebral column. Now, one of the applications of the understanding the anatomy of the spinal nerves is being able to interpret dermatome maps. And a dermatome map, which is shown here, is actually a mapping of the body of somatosensory input. So this is conscious sensation And basically what we have are is a mapping out of areas of the skin where the sensory input is conveyed by particular spinal nerve pairs. So for example, if we look at this layer around the belly button, so around the trunk of the body, all the sensation on the surface of the skin around this band is conveyed to the brain through spinal nerve pair thoracic 10. Okay. So what this allows you to do is if there is a loss of sensation or altered sensation anywhere on the body, depending on where it is, allows you to understand where the root cause of the problem is. So for example, numbness or tingling in the middle finger and parts of the ring finger and index finger suggest that there is maybe a pinched nerve or a herniated disc at the spinal nerve pair at cervical level 7. Okay. So it allows you to connect sensory changes to the corresponding spinal nerve pairs. Now there's a similar map, I don't have a picture of it, but there's a similar map for voluntary muscle control. What we call that is a motor map or a myotome map. And what that would look like are groups of muscles that would also be labeled based on the spinal nerve pair that innervates and controls those muscle groups. Now, if we look at the spinal cord where the spinal nerves are coming out of, we have two areas in the spinal cord. We have what's called white matter and we have gray matter. Now, the gray matter is darker in color and it's found at the center of the spinal cord. Sometimes I like to describe it as looking like a Honda symbol. And the gray matter is where we find the cell bodies of these nerve cells. Okay. So the gray matter is where the cell bodies of these nerve cells are sitting, and we have synapses or connections to these cell bodies coming into or out of the spinal cord. And the parts of the gray matter in terms of the dorsal side versus the ventral side, it also, like we saw before with the dorsal root and the ventral root, it divides sensory versus motor. So the synapses that are found on the dorsal side of the gray matter, okay, what we call actually the dorsal horn, are all sensory. And then what we find in the ventral horn, or the ventral part of the gray matter on both sides, are cell bodies of motor neurons that are going and stimulating skeletal muscle. Okay. Now the white matter, it appears white because what we have in the white matter are axon fibers, where the white is coming from the myelination. Okay. So the myelination is high in lipid, it's high in fat. So the collection of axon fibers in the white matter makes it look white. And now, of course, in this slide, it's actually drawn and colored in either blue or green to make it very clear. And what the differentiation between blue and green is in this picture is the difference between blue is ascending tracks, meaning axons traveling upwards towards the brain, or green are the descending tracks, which are motor tracks or efferent tracks moving down from the brain and down the spinal cord. And so again, whether a track is ascending or descending also depends on whether it's sensory or motor, or afferent versus efferent. And again, the dorsal surface, we have an abundance of ascending sensory tracts, and in the ventral surface, we have an abundance of descending motor tracts. So this is a better picture of the horns of the gray matter. So we see the dorsal horn, the dorsal part of the gray matter is where the somatosensory nerves are coming in and synapsing. The ventral horn is where the cell bodies of the motor neurons are sitting, and they will branch out and innervate muscle. And then in the middle portion of the gray matter, we have what's called the lateral horn, which are actually cell bodies of autonomic nerves. Okay? And again, these autonomic nerves control visceral function or organ function and maintain the body beyond what we're aware of. So just to give an illustration of what it looks like, the interaction between the gray matter, the cells in the gray matter, and the spinal nerves that are branching out at each section of the spinal cord. The example I'm giving here, or I'm using here, is a spinal reflex called the patellar reflex. Now, the patellar reflex is a classic spinal reflex where if we tap on the patellar ligament, okay, we get this reflexive kick of the leg. And what's actually happening with the patellar reflex is when we hit the patellar ligament, we very quickly and momentarily stretch the quadricep muscle. Okay? And that stretch triggers a sensory fiber that is designed to prevent tearing of the muscle, okay, or stretch that happens too quickly. And when this sensory nerve, labeled here the muscle spindle, gets triggered by that patellar reflex, it causes a reflexive contraction of that quadricep muscle and relaxation of the hamstring that brings about that little kick. Okay? And so if we stretch this muscle very quickly, it reflexively contracts to prevent tearing. So the way this reflex works is that we have to send sensory information to the spinal cord, and then the spinal cord transmits that sensory information into a motor command that creates the kick. Okay? And so as a spinal reflex, this reflex requires no input from the brain. It simply requires an intact spinal cord at the level of L2 through L4. So if we look at this for a second, so we hit the patellar ligament, we stretch the quadricep muscle, and we activate this muscle spindle. And that sensory message of stretch gets travels back to the spinal cord, right, through this sensory nerve, enters the spinal cord through the dorsal root, and then synapses at the dorsal horn. Okay? And it contacts interneurons that then control two motor neurons that are going to control the quadricep and the hamstring muscle. And the motor neuron that controls the quadricep causes contraction, it stimulates, and the motor neuron that controls the hamstring is going to inhibit or relax the hamstring to make this kick possible. Okay? And you can see the motor neurons, they're sitting in the ventral horn of the spinal cord. They are leaving the spinal cord through the ventral root. They're merging into the spinal nerve, and they're going and innervating the muscles. Okay. So this spinal reflex gives you an idea of what it looks like when sensory information is coming into the spinal cord versus motor information coming out. Now, the vast majority of what we've talked about so far has been the what we call the somatic nervous system, meaning the part of our nervous system that we involves sensations that we are consciously aware of, and motor movements that we can voluntarily control. Another part of our nervous system is what's called the autonomic nervous system, which operates without our awareness and without the need for us to voluntarily control it. Okay? So this is our involuntary control of visceral function or organ function. Okay? And the sensory component of this system involves the regulation or the monitoring of these organs that then create whatever commands that are necessary. So, for example, the autonomic nervous system constantly senses the heart rate and blood pressure and the overall blood flow to the body, and it can, in response, trigger an increase in heart rate or an increase in blood pressure or constriction of blood vessels, right, depending on what's necessary. Right? So that kind of sensory information and efferent commands are beyond our conscious awareness, and it's also involuntarily controlled. And there are two divisions of this autonomic nervous system. There's what's called the sympathetic division, which is also known as our fight or flight response, and then we have the parasympathetic division, also known as our rest and digest. Okay. And the sympathetic nervous system controls all responses that are stress-related. Okay? While the parasympathetic nervous system controls all responses that are associated with the resting state. Okay? So if we need an increase in heart rate, the sympathetic division will stimulate the heart. If we want a decrease in heart rate, the parasympathetic division will slow the heart rate down. Okay? And as you can see, both divisions of our autonomic nervous system make contact on most of the organs of our body. Okay? There's a couple of exceptions that they only receive parasympathetic or sympathetic, but the vast majority of the targets are innervated by both systems. Okay? And normally what's happening is that both systems are active, but just in different amounts. So, for example, at rest, during most of the time, the parasympathetic division is dominant. So we have parasympathetic input to a greater degree than sympathetic input. Okay? And then when we need to activate a stress response, for example, during exercise, the dominance shifts, and so the parasympathetic input goes down and sympathetic input goes up. Okay? And so they're both usually active, but the balance changes depending on whether you're in a resting state or a stress-related state. Now, there are two important neurotransmitters of the autonomic nervous system. There's acetylcholine and norepinephrine. Now, acetylcholine is released by the parasympathetic nervous system onto target organs, and norepinephrine is released by sympathetic nerves onto target organs. Now, if we look at the interaction between these different types of nerves and the target organs, okay, we can, so the bottom here is the autonomic nervous system, parasympathetic and sympathetic. And the top here is the somatic nervous system. So this is a motor neuron acting on the skeletal muscle. So the somatic nervous system, motor neurons also release acetylcholine, and they bind to a particular type of acetylcholine receptor called the nicotinic N1 acetylcholine receptor. And the receptor isn't so that's why I'm mentioning it. Now, if we look at the parasympathetic nervous system, the part of our autonomic system that releases acetylcholine onto target cells, acetylcholine is actually binding to a different receptor on target organs called the muscarinic acetylcholine receptor. Okay. Now, with a sympathetic system, our fight or flight, this system releases norepinephrine. The nerves release norepinephrine. And the target cell receptors tend to fall into two types, either an alpha receptor or beta receptor. And then also part of the sympathetic nervous system is the adrenal gland. And the adrenal gland is an endocrine gland that sits on top of each kidney. There's two adrenal glands. And the adrenal gland actually has two distinct parts. There's the inside of the gland called the adrenal medulla, and then there's the outside of the gland called the adrenal cortex. And the adrenal medulla, the inside, is actually part of the sympathetic nervous system. So during a fight or flight response, during a stress response, the adrenal medulla is going to release epinephrine into the bloodstream. Okay? And epinephrine is going to be the hormone that will then act on target cells and will act mostly on beta receptors. Okay? Epinephrine and norepinephrine are very similar in structure. Epinephrine can bind to both alpha and beta receptors, but it prefers beta receptors. It has a particular affinity for beta receptors. So, an important category of drugs to be familiar with are drugs that affect autonomic function, or drugs that fall into either cholinergic drugs that interact with the acetylcholine, either acts like acetylcholine or blocks acetylcholine receptors, and adrenergic drugs, or drugs that can act like norepinephrine, epinephrine. Okay. The cholinergic drugs will fall under a couple of different categories depending on what receptor they interact with. Okay. So we have what's called muscarinic agonists, which are drugs that act like acetylcholine and bind to the muscarinic receptors. We have muscarinic antagonists that bind to the muscarinic receptors and then block any effects. Okay, they are blockers. There's another group of drugs called cholinesterase inhibitors, and what this category of drug does is it prevents the digestion of acetylcholine, and so it actually acts like an acetylcholine agonist. Okay, and it will stimulate both muscarinic and nicotinic receptors. And then we have specific nicotinic drugs that stimulate or block nicotinic receptors. And the nicotinic receptors we're going to talk about are strictly, for our purposes, are going to be the nicotinic receptors that are on skeletal muscle and control muscle movement. And then we'll also talk about adrenergic drugs, adrenergic agonists, antagonists, and what we call indirect anti-adrenergic agonists, which act similar to adrenergic blockers. So let's look at the cholinergic drugs first, the drugs that interact with the acetylcholine system. So the receptors that are relevant for this includes the nicotinic, the N1, that are found on skeletal muscle, and control muscle movement. And then we have a variety of muscarinic receptors that are part of the parasympathetic nervous system. There are muscarinic receptors that we find in the brain, muscarinic receptors on the heart and smooth muscle of the blood vessels. We have muscarinic receptors that are found on the glands, exocrine, endocrine glands, and smooth muscle of organs. Okay. Now, when the acetylcholine system is stimulated, the effects of acetylcholine on the body are pretty predictable, and they will be very similar to the effects of the parasympathetic nervous system. So they will trigger a rest and digest response. So in the cardiovascular system, acetylcholine triggers things like vasodilatation, a decrease in heart rate, a decreased force of cardiac contraction. In the respiratory system, acetylcholine will stimulate bronchoconstriction and increased airway secretions. In the urinary tract, acetylcholine will trigger bladder contraction, and it will promote voiding or urination. In the GI tract, acetylcholine increases motility or movement and secretion. And in other systems, acetylcholine is going to increase lacrimal secretion, which is basically the production of tears in the eyes. Also will stimulate nasopharyngeal and salivary secretion and will cause constriction of the pupils. So these are the effects of acetylcholine on the body, and as you can tell, these are very consistent with a resting state. So the first category of drugs for us to mention and understand is the muscarinic receptor agonists. And there's only one that we need to remember, and this drug is called bethanechol. And bethanechol, which is right here, you definitely do not need to memorize the structure at all. But this here is acetylcholine. This is the chemical structure of acetylcholine. And as you can see, that the bethanechol is very similar, right? It looks very similar to acetylcholine. So bethanechol is an agonist. It binds to muscarinic receptors and can activate it like acetylcholine activates it. Okay. So because it's a muscarinic agonist, it stimulates muscarinic receptors just like acetylcholine. We sometimes refer to it as a parasympathomimetic, meaning it mimics the parasympathetic effect on the body. It's very selective for the muscarinic receptors. In the heart, it causes bradycardia. In smooth muscle, it can cause constriction of airways. In the GI system, it increases muscle tone and movement. In the bladder, it causes contraction of the detrusor or the bladder muscle and stimulates urination. It also stimulates exocrine glands, so you get more sweating, more salivation, more airway secretions, and more secretion of acid in the stomach. And in the end, you get constriction of the pupils, okay, which is referred to as meiosis. So those are the effects of bethanechol on the body. So why do we use bethanechol therapeutically? So in clinical settings, bethanechol is used for a couple of different things. It is used to treat urinary retention, right? Since bethanechol will cause urination, it's very good to treat the retention of urine. And there are some investigational uses into stimulating GI function as well. Okay. But bethanechol can be very helpful in stimulating stimulating urination, especially after surgery, when people are catheterized for a while. Adverse effects of the use of bethanechol, as we can probably predict, can cause a decrease in blood pressure or hypotension. It can cause too much stimulation of the GI system, which can lead to diarrhea. It can exacerbate asthma because it causes bronchoconstriction, and it can also cause dysrhythmias in patients with hyperthyroidism. Now, going in the other direction, let's talk about muscarinic antagonists, okay, which can also be called anticholinergic drugs. Muscarinic antagonists block the actions of acetylcholine at muscarinic receptors. Okay? These drugs are sometimes called anti-muscarinic drugs, muscarinic blockers, as I said, anticholinergic drugs, and also sometimes called parasympatholytic. Lytic meaning preventing parasympathetic input, right? Or dissolving parasympathetic input. Okay. So anticholinergic drugs are going to block muscarinic receptors and block the parasympathetic nervous system. So what's interesting and important to remember with anticholinergic drugs is that you have drugs that are muscarinic antagonists that are clearly anticholinergic. And then we also have some drugs that don't primarily act as muscarinic antagonists, but they do have some anticholinergic effects. Okay? And there's actually quite a few drugs that have anticholinergic effects, including things like antihistamines, tricyclic antidepressants, phenothiazine, and some antipsychotics. Okay, and these drugs are usually used for other reasons, right? They're not usually used to cause anticholinergic effects. But if you use these drugs along with other anticholinergic drugs, you can get some significant adverse effects in certain patients. Okay? And the most common patients that we worry the most about too much, the use of too many anticholinergic drugs, is the elderly. So our prototypic anticholinergic drug is atropine. Okay? It's the best known muscarinic antagonist. It's actually found in nature. It's found from the fruit of the belladonna plant, and it causes direct blockade of the muscarinic receptor. Okay. So the effects on the body of atropine is, since it's blocking parasympathetic input, it causes an increase in heart rate. It decreases secretions. It will actually relax the muscles in the airway. It will relax the bladder so you retain urine. And it actually will decrease activity in the GI tract. It also in the eyes will cause what we call mydriasis, which is pupil dilation. And then atropine also can act on those muscarinic receptors in the brain and can cause some mild excitation or hallucinations and delirium. Okay? But that's usually at higher doses. Okay? But anticholinergic drugs, like the ones I mentioned earlier, the antihistamines, the antipsychotics, when combined with other anticholinergic drugs like atropine, especially in the elderly, can have more of these central nervous system effects. Okay, so too much anticholinergic effects on the body in the elderly are more prone to delirium, hallucination, or changes in cognition. So what do we use atropine for therapeutically? It's used as a pre-anesthetic medication. It can also be used to dilate the pupils of the eye. It can be used to lower heart rate. It can be used to treat, it can be used to treat bradycardia, right, to increase heart rate. It can be used to treat hypertonicity and hypermobility of the gut, to basically reduce that. It can block muscarinic agonist poisoning. It can be used to treat peptic ulcer disease because it's going to reduce gastric acid or stomach acid production. It can be used to treat asthma because it will cause relaxation of the airways. And it can be used to treat biliary colic because, again, it's going to relax the smooth muscle of the bile ducts. Okay. Adverse effects of atropine. It decreases secretion, so it can cause dry mouth. It can cause blurred vision and photophobia because of the pupillary dilation. It can actually increase intraocular pressure, again because of pupillary dilation. It can cause urinary retention and the negative effects of that, cause constipation, anhidrosis, tachycardia, and asthma. Drug interactions with atropine, as I mentioned before, you want to avoid combining atropine, which is an anticholinergic drug, with other drugs that are capable of causing muscarinic blockade. So antihistamines, the tricyclic antidepressants, some of the antipsychotic drugs, okay? Atropine can be used for general systemic therapy. You can also deliver atropine through an automated pen called the AtroPen, which can be used for the treatment of what we call cholinesterase inhibitor poisoning. And the most common application for this AtroPen is in soldiers that are going to war. Cholinesterase inhibitor poisoning, one form of cholinesterase inhibitor that can cause poisoning is nerve gas that can be used in times of war. And nerve gas is a cholinesterase inhibitor. It blocks the digestion of acetylcholine. You get too much acetylcholine onto the skeletal muscle, and the muscle goes into tetanus and it becomes paralyzed. And one of the major worries for this is that the diaphragm, which is a major muscle controlling breathing, nerve gas can paralyze that muscle and cause death. So soldiers are equipped with these AtroPens, which they can inject themselves with into the thigh, and it gives them a dose of atropine if they feel like they've been exposed to nerve gas. And then atropine can also be found in eye drop form to cause pupillary dilation by ophthalmologists. We have some other muscarinic antagonists, and these are drugs that have a high ability to cross the blood-brain barrier and can act on the central nervous system. So these muscarinic antagonists or anticholinergic drugs are used to treat things like Parkinson's or drug-induced Parkinsonism, which is a form of Parkinsonism that is induced by certain drugs. And so if you remember when we talked about the basal ganglia, Parkinson's disease was caused by an imbalance between dopamine and acetylcholine in the basal ganglia because the dopamine was getting depleted. And so by blocking acetylcholine in these Parkinson's patients, you help bring about a better balance between acetylcholine and dopamine in the brain. So muscarinic agonists, if we get too many or taking too much muscarinic and agonists, so the muscarinic agonists are the drugs that overstimulate or stimulate the muscarinic receptors. So some of these are direct-acting muscarinic agonists like bethanechol, and also cholinesterase inhibitors because they block the digestion of acetylcholine. And the symptoms, it really results from an excess activation of muscarinic receptors. And the treatment is a muscarinic blocking agent like atropine. Okay, so an example of this I mentioned earlier was the nerve gas, right? Nerve gas is a cholinesterase inhibitor, and the way that we can reverse the effects, or the antidote, is atropine, because it blocks the muscarinic receptor. So, in terms of the toxicity levels and toxicity effects of muscarinic antagonists, okay? So these are the blockers. What we see with too much anticholinergic effects is things like dry mouth, blurred vision, photophobia, hyperthermia, elevated body temperature. We see central nervous system effects like hallucination and delirium. And the skin feels hot, it's dry, and it's flushed. Okay, so this is too much blocking of the muscarinic receptor. If we give atropine in an inappropriately high dose, or we combine a drug like atropine with antihistamines or other drugs with anticholinergic effects, we get, like I said, dry mouth because we get decreased secretion, blurred vision and photophobia because the pupils dilate, hyperthermia, body temperature goes up, and that's mostly because you stop sweating, and your body can't get rid of excess heat because you stop sweating. You also see effects in the central nervous system, the hallucination, delirium, and the skin is hot, dry, and flushed, again because you have a hard time getting rid of heat because you're not sweating. So that group of patients, the elderly patients, are much more susceptible to this. Okay, so these effects are more readily seen in elderly patients who are taking more than one anticholinergic drug. Now, cholinesterase inhibitors are drugs, I mentioned this earlier, are drugs that block the digestion of acetylcholine. And because they block the digestion of acetylcholine, they actually act like agonists. Okay? They end up allowing too much acetylcholine and more stimulation of the acetylcholine receptors. But it lacks sensitivity in terms of what receptors. So any receptor that can respond to acetylcholine, the muscarinic receptors or the parasympathetic system, or the neuromuscular ones, the ones on skeletal muscle, they will all respond to the excess acetylcholine. So cholinesterase inhibitors are really only used therapeutically, clinically, mostly to treat a disease called myasthenia gravis. And myasthenia gravis is a disease where people have a loss of skeletal muscle tone. So it's a disease of progressive muscle weakness. And so the use of acetylcholine, the use of cholinesterase inhibitors helps to combat this muscle weakness. Now, the most common cholinesterase inhibitors, they include what we call neostigmine, physostigmine, and edrophonium. Okay. Now, edrophonium is an ultra short-acting cholinesterase inhibitor that is really only used for one application, and we'll talk about that later. Neostigmine and physostigmine are much more commonly used in the treatment of myasthenia gravis. So myasthenia gravis, what we see with this is we see this fluctuating muscle weakness and this predisposition to rapid fatigue. Common symptoms, we see drooping of the eyelids, difficulty swallowing, and weakness of skeletal muscles. What's going on with myasthenia gravis is that the immune system, it's an autoimmune disease, the immune system is attacking those nicotinic receptors on the skeletal muscle. And so the muscle has less of an ability, it has fewer receptors to respond to acetylcholine. So cholinesterase inhibitors help produce a relief that is purely symptomatic. Okay, so the cholinesterase inhibitors makes more acetylcholine available so that you can compensate for the loss of receptors. Okay? And so patients are going to need this therapy lifelong. Okay, this drug therapy lifelong, because it's not correcting the autoimmunity. It's just helping to relieve the symptoms. So when we treat with these cholinesterase inhibitors, the most common side effects we see for these patients with myasthenia gravis is excessive muscarinic stimulation. So remember, the cholinesterase inhibitors are in the patients with myasthenia gravis, we're increasing acetylcholine in order to stimulate skeletal muscle. But we're also increasing acetylcholine associated with the parasympathetic nervous system. And so the side effects mostly involve excess muscarinic responses. Okay? And so atropine, the muscarinic antagonist, can be given occasionally to reverse those side effects. Now, the big challenge with treating cholinesterase inhibitors, treating myasthenia gravis with cholinesterase inhibitors, is determining the dosage, because it's going to be highly individualized. You really want to give them the least amount of drug that allows for therapeutic effect. So you're going to start very small, and you're going to adjust the dosage based on how the patient responds. And you're going to keep track of things like time of administration, muscle strength before and after administration, how long it takes for them to fatigue, and signs of muscarinic stimulation. And then later on, once you get a good baseline dose, there's a lot of patient teaching involved, because the patients need to learn how to adjust their dose based on things like whether they anticipate exercise, or if they notice that they are experiencing some eye drooping or difficulty swallowing. Okay, so they need to learn signs of under-medication, which is the eye drooping and difficulty swallowing, and signs of over-medication, which is too much muscarinic stimulation, like excess salivation and other muscarinic responses. Now, one major problem with treating myasthenia gravis with cholinergic drugs is that the symptoms of too much drug actually looks fairly similar to the symptoms of not enough drug. And if you don't know much about the patient, you may not be able to tell the difference. So the problem of too much drug is called cholinergic crisis. So if a patient their dose is too high, or they accidentally took too much of the cholinesterase inhibitor, they are going to have too much acetylcholine overstimulating the skeletal muscle, which is going to make the muscle go into tetanus and stop responding. So this is characterized by extreme muscle weakness, frank paralysis, and signs of excessive muscarinic stimulation. And so the treatments are respiratory support and atropine. The atropine is going to help block the muscarinic stimulation. The respiratory support is to make sure that the diaphragm is working, right, and you're waiting for the drug levels to come down. With myasthenic crisis, you have not enough drug, okay, and so the patient has extreme muscle weakness, and it's caused by not enough acetylcholine at the stimulating the muscle. And if left untreated, myasthenic crisis can result in death as a result of paralysis of the diaphragm. And the treatment is giving drug, right? Neostigmine, physostigmine, which is used to relieve the crisis. Now, if you don't know enough about a patient to figure out which one they're in, if they present with this extreme muscle weakness, frank paralysis, and you don't know whether it's a problem of too much drug or not enough, there's a challenge test that's done with a dose of edrophonium. And edrophonium is that ultra short-acting cholinesterase inhibitor. And so if you give edrophonium, either the symptoms are going to get worse very temporarily, or they're going to get better. Okay? Now, if you give edrophonium and they get better, then you know that they're in myasthenic crisis, okay? Because they didn't have enough drug and you gave them a little bit of drug and they got better. If they don't improve, if you give the edrophonium and the symptoms worsen, then you know that the problem has been cholinergic crisis, because they had too much drug, you gave them edrophonium, which is more drug, and they very temporarily got worse. Okay? So this test dose of edrophonium is a way to distinguish between this cholinergic crisis and myasthenic crisis. So neostigmine is our prototypic drug for cholinesterase inhibitors. At therapeutic doses, it tends to primarily affect the muscarinic receptors and the neuromuscular junction. But at toxic levels, if your dose is much too high, it can depress CNS function, especially respiration. Administered orally or via an IM injection, it's really absorbed poorly through an oral administration because it's very positively charged and doesn't get absorbed very well in the GI tract. It's contraindicated in patients on Succinylcholine, which is a neuromuscular junction blocker. Precautions and contraindications. Any obstruction of the GI tract or the urinary tract, you don't want to use neostigmine. Peptic ulcer disease, asthma, coronary insufficiency, hyperthyroidism. Okay? The acetylcholine produced by the neostigmine in those conditions are going to make the conditions worse. Physostigmine is the other cholinesterase inhibitor, and it's really the drug of choice for treating poisoning by atropine and other muscarinic blockers like antihistamines and antipsychotics. And the reason why, so too much anticholinergic drug, you're going to give physostigmine because physostigmine actually crosses the blood-brain barrier and can relieve more of the central nervous system problems. Okay? Okay, so switching gears to another very, very different kind of cholinergic drug are the neuromuscular blockers. These are antagonists, blockers of the nicotinic receptor, okay, the nicotinic receptor on skeletal muscle. So they will block skeletal muscle stimulation. Okay, and there's two types of neuromuscular blockers. There's what's called depolarizing or non-depolarizing. Non-depolarizing are classic blockers. They just sit on the receptor and they block acetylcholine. The depolarizing ones overstimulate the muscle and keep it paralyzed through overstimulation. Okay. There's no oral forms of these neuromuscular blockers, okay, because it can't. It has really no oral bioavailability. They also can't cross the blood-brain barrier, so they don't cause sedation or central paralysis. And they really cannot cross the placenta, so they don't really have effects on the fetus. Okay. So, as I said, these two different types of neuromuscular junction blockers, the non-depolarizing ones simply block the receptors, but the depolarizing ones actually overstimulate the muscle. Okay, I'm not going to go too much into the control of muscle contraction, but basically you stimulate the muscle through electrical impulses, but too much stimulation and the muscle becomes paralyzed and it stops responding. And that's actually how those depolarizing neuromuscular blockers act. Okay. So our typical non-depolarizing simple blockers of the neuromuscular junction is tubocurarine. It's the oldest competitive neuromuscular blocker. It's actually the active ingredient in what's called curare, which is a plant extract, and it's found throughout South America. It's often used to cover the arrows of hunters in South America because when they shoot their prey, it actually paralyzes them and it makes it easier makes hunting easier. So tubocurarine, it's the oldest competitive blocker, but it's no longer used in the United States, and it's been replaced by newer neuromuscular muscular blockers like pancuronium, atracuronium, cis-atracuronium, and others. Okay. The non-depolarizing neuromuscular junction blockers, mechanism of action, like I said, is it competes with the acetylcholine for the nicotinic receptor. It can't cross the plasma membrane, so it doesn't cross the blood-brain barrier or get absorbed orally. The paralysis is within minutes of the IV injection, and it persists between 20 to 45 minutes, and a complete recovery takes about an hour. So we end up with flaccid paralysis, muscle relaxation. We end up with a decrease in blood pressure. We don't see any central nervous system effect, and it's used to provide paralysis during surgery or mechanical ventilation or endotracheal intubation. Okay. Adverse effects, respiratory arrest, and hypotension. So precautions and contraindications with the neuromuscular blockers. We have to use great care when we're using these neuromuscular blockers with myasthenia gravis because they will require far lower doses. Okay? They already have decreased muscle stimulation, so they'll need far less. You also see changing effects when the patient's in electrolyte imbalances. So things like hypokalemia enhances paralysis, hyperkalemia reduces the paralysis. And then drug interactions, because the neuromuscular blockers are rarely used by themselves, usually used with other anesthetics. So inhaled anesthetics also cause muscle relaxation, so we need less of the neuromuscular blocker. And some antibiotics can intensify the effects, so we have to be aware of what other drugs the patient's taking. Okay, so pancuronium. The advantages to pancuronium is you get less hypotension. Okay, you get less hypotension, so it's a good choice in terms of that. The you may get some tachycardia, and you want to use it with caution in patients with liver disease, since it's metabolized by the liver. And the excretion is primarily through urine, so you want to be careful with patients who have decreased kidney function. The atracurarium can cause hypotension, but the atracurarium is a better choice for patients with liver and kidney problems because it's not eliminated or metabolized by the liver or kidneys. Okay. So in a patient with liver or kidney problems, atracurarium is going to be a better choice than pancurarium. You don't have to worry about the next three. You can read it and understand it if you'd like, but I want you to know the pancurarium and the atracurarium. There's only one depolarizing muscular junction blocker that we're going to talk about, and there's only one in clinical use, and that's succinylcholine. And succinylcholine creates muscle paralysis by overstimulating the muscle, okay? And that leads to paralysis of the muscle. Succinylcholine, what's nice is that it is ultra short-acting. The muscle paralysis is a state of flaccid paralysis, and it also has no central nervous system effects. The effects peak at 1 minute, and it fades over 4 to 10 minutes. So it's a really great choice for very brief paralysis. So the muscle relaxation, so it's used for things like mechanical ventilation, during intubation to suppress the gag reflex. And it's also used during electroconvulsive therapy to prevent convulsions when the person's getting their electroshock therapy. Now, drug interactions, because succinylcholine actually stimulates the muscle, you don't want to use cholinesterase inhibitors with succinylcholine because you can actually end up potentiating or increasing the effects of the drug. And then certain antibiotics also can increase the effect of succinylcholine, so you don't want to use them together. So some adverse effects that we've seen with succinylcholine. With certain patients, we can see prolonged apnea because of paralysis of the diaphragm. But the one thing that we are most concerned about with succinylcholine is the occurrence of malignant hyperthermia. And it's rare but potentially fatal condition that can be triggered by the drug. And what happens is the body temperature gets very, very high. The muscle gets very rigid. It can trigger cardiac dysrhythmias, unstable blood pressure, electrolyte changes, metabolic acidosis. And if it's left untreated, if it's not immediately treated, the condition can rapidly prove fatal. And it's a genetically determined reaction, so we don't know who's going to react this way. So monitoring body temperature when you give succinylcholine is going to be very, very important, and discontinuing the drug at the earliest sign of any increase in muscle rigidity or body temperature is going to be critical. So treatment is going to be immediate discontinuation of the drug, cooling the patient with ice packs or intravenous infusion of cold saline, administering intravenous datrolene, which stops heat generation by acting on the skeletal muscle to reduce its metabolic activity. Okay. Other adverse effects with succinylcholine, fairly common one is postoperative pain. So when we use succinylcholine, because it can produce an initial muscle contraction before it causes the paralysis, between 10 to 70% of patients receiving succinylcholine experience muscle pain. And the most common pain is in the neck, shoulders, and back. And the pain can develop 12 to 24 hours after surgery, and it can persist for several hours or even days. Overstimulates the muscle, can also cause hyperkalemia because it promotes the release of potassium from the tissue. It rarely produces severe hyperkalemia, but it can. And the thing we worry about with hyperkalemia getting too high is cardiac arrest. And significant hyperkalemia is most likely to occur with patients who already have problems that increase the movement of potassium out of tissues, like major burns, multiple traumas, denervation of skeletal muscle, or upper motor neuron injury. Excuse me. Okay, so we're going to switch now and talk about adrenergic drugs, the drugs that interact with norepinephrine, epinephrine, and the receptors that bind to those mediators. And we're going to start with the adrenergic agonists, the drugs that can act like norepinephrine and epinephrine. So they produce their effects by activating adrenergic receptors. They are what we call sympathomimetic, meaning they mimic the sympathetic nervous system, and they trigger fight or flight responses. They have broad spectrum applications like congestive heart failure, asthma, preterm labor. Now, there are two types of adrenergic agonists, two basic types. We have the catecholamines, which include norepinephrine, epinephrine, isoproterenol, dopamine, and dobutamine. And then we have the non-catecholamines, which include ephedrine, phenylephrine, and terbutaline. So the catecholamines, some of the key differences between the catecholamines versus non-catecholamines, probably the most important one to keep in mind is that the catecholamines can never be used orally, so they can never be taken orally, while the non-catecholamines can be taken orally. Okay. So the catecholamines, these drugs, must be given either through an IV injection or an IM injection or some non-oral route, while the non-catecholamines can be given orally. And the catecholamines also cannot cross the blood-brain barrier, so they have no effects on the brain, while the non-catecholamine drugs do cross the blood-brain barrier. So these major drugs, adrenergic receptor agonists, you can see some of the drugs like epinephrine have broad selectivity. Ephedrine also, norepinephrine to a lesser extent. Phenylephrine is only active at alpha-1 receptors, right? As is dopamine, along with, I'm sorry, not dopamine. So you can see the different drugs have different specificities in terms of receptors. And so what do we see when we stimulate alpha receptors? Alpha 1 receptors, we get vasoconstriction and decreased bleeding. Okay? So we trigger the clotting cascade and we trigger vasoconstriction. We also see nasal decongestion. So notice that phenylephrine stimulated alpha 1. So I don't know if you recognize phenylephrine, but phenylephrine is found in nasal decongestants that we take over the counter when we have a cold. And that is because it causes constriction of the blood vessels that produce mucus. Okay. Alpha 1 receptors can also be used along with local anesthetics because it creates constriction of vessels, which means that you keep that anesthesia in that one local area. It delays absorption, so it prolongs the effect in that local area. Elevation of blood pressure through vasoconstriction and pupillary dilation, that mydriasis. Okay. Those are the drugs that stimulate alpha 1 receptor. These are the effects. And the drugs that are capable of activating alpha 1 receptors include epinephrine, norepinephrine, phenylephrine, and dopamine. When we activate beta 1 receptors, we are targeting the heart when we're activating beta 1 receptors. Okay? Even though we see beta 1 receptors in other locations, at the doses we normally give these drugs, the beta 1 receptors are coming, that they're stimulating, are going to come from the heart. Okay? And the beta 1 receptor drugs that we use include epinephrine, norepinephrine, isoproterenol, dopamine, dobutamine, and ephedrine. Therapeutic applications of beta 1 activation. Why do we use beta 1 agonists? Shock. Okay, so drop in blood pressure, we can use beta 1 activation to increase heart rate, increase cardiac output, so that we deliver more blood to the body. Profound hypotension, greatly reduced tissue perfusion. Primary goal of treatment is to maintain blood flow to vital organs. Beta 1 stimulation increases heart rate and force of contractility. We get increased cardiac output and better tissue perfusion. We also use beta 1 activation with heart failure. Again, because it increases force of contraction and can increase cardiac performance. We also can use beta 1 agonists to treat AV heart block. We activate those beta receptors and enhances impulse conduction through the AV node, which can help overcome an AV block. Okay. And the drugs are only for temporary treatment. For long-term management, you're going to need a pacemaker to treat AV block. Acute resuscitation of cardiac arrest, beta receptors, beta 1 receptors, and the drug of choice is epinephrine. Okay, so in the event of a cardiac arrest, when we are acute resuscitation, we want to activate those beta 1 receptors, get the heart pumping, and get blood moving, and we use epinephrine for that. We also can use beta 1 agonists to treat dysrhythmias. We can use it to treat angina pectoralis, which is chest pain. Now, I'm sorry, adverse effects of beta 1 activation. Adverse effects of beta 1 activation is that we can cause dysrhythmias because of this increase in heart rate and contractility. And we can also cause chest pain, angina pectoralis, because when we stimulate beta agonists, we're actually going to increase the heart's oxygen demand, okay? Which can, if the heart can't supply adequate blood to match that demand, we're going to end up with chest pain. Now, when we are activating beta 2 receptors, our targets are going to either be the lungs or the uterus. Okay? So beta 2 agonists are either designed to stimulate the lungs or stimulate beta receptors in the uterus, which actually ends up in the lungs. That causes bronchodilation and increased ventilation. And in the uterus, beta 2 agonists actually cause uterine relaxation, and it's used to decrease the risk of preterm labor. And the beta 2 activating drugs include epinephrine, isoproterenol, and albuterol. Now, dopamine, which is also an adrenergic agonist, is used to treat shock. Dilation of the renal blood vessels reduces the risk of renal failure in shock. So dopamine is very good at dilating the renal arteries and increasing renal perfusion so that your kidneys don't fail when blood pressure drops in shock. Okay. It also enhances cardiac performance by activating beta 1 receptors in the heart. Okay, so dopamine during shock is a good way of increasing renal perfusion to prevent renal failure and increasing cardiac performance by activating beta 1 receptors. Now, anaphylactic shock, we actually use multiple receptor activation when we treat anaphylactic shock. An anaphylactic shock is a severe allergic response, and what we see is hypotension, a drop in blood pressure. We see bronchoconstriction, and we also see edema of the glottis, or potentially compromising the airway. The treatment of choice is epinephrine. Okay, so epinephrine is the treatment of choice for anaphylactic shock, because it's going to help oppose the hypotension, oppose the bronchoconstriction, and reduce that edema of the glottis. So epinephrine is our prototypic catecholamine. It's used therapeutically to delay absorption of local anesthetic because it causes constriction locally. Controls superficial bleeding, it elevates blood pressure, overcomes AV block, restores cardiac function during arrest, causes bronchiolar dilation in patients with asthma, and is the treatment of choice for anaphylactic shock. Absorption of epinephrine, remember it's a catecholamine, so you can't take it orally, and it doesn't cross the blood-brain barrier, so you have to give it either through an intramuscular injection, sub-Q injection, or intravenous. Okay? It has a short half-life, so it doesn't really last very long when you put it in the body. Adverse effects of epinephrine, you can cause hypertensive crisis, which is caused by too much vasoconstriction. We have this dramatic increase in blood pressure, and you can cause hypertensive crisis can cause cerebral hemorrhage. Dysrhythmias, when we activate the beta 1 receptor too much, you can produce dysrhythmias. Okay? Chest pain, angina pectoralis, again from overstimulation of beta 1 receptors, causes increased oxygen demand on the heart. And if extravasation happens with injection of epinephrine, it can cause necrosis at the site. And you also can cause hyperglycemia in diabetic patients because epinephrine has the tendency to elevate blood sugar. So preparations of epinephrine, we have a self-injecting EpiPen, which is very good for patients to have on hand if they have severe allergies. We have IV administration, which we're going to very closely monitor, because when we give epinephrine IV, we increase the likelihood for those adverse effects. We have IM injections, sub-Q, rarely used, but intracardiac injections. So if an IV is not a possibility and your patient's in asystole, it's very dramatic, but you can actually inject epinephrine through the sternum into the heart. Intraspinal epinephrine is possible. Inhalation epinephrine, which is going to be very good for bronchodilation, and topical uses of epinephrine, which would be very good for that extension of the local anesthetic. Okay. Norepinephrine is another catecholamine. It has specificity at alpha-1, alpha-2, and beta-2 receptors. Therapeutic uses, used to treat hypotensive states, cardiac arrest, and it does not promote hyperglycemia in diabetic patients, which is nice. But it cannot be given orally, and it does not cross the blood-brain barrier. Isoproterenol acts on beta-1 and beta-2 receptors. So beta-1, one heart, two lungs. Excuse me. It's going to act on the heart and the lungs. Therapeutic uses are to treat AV heart block, cardiac arrest, increase cardiac output during shock. It has fewer adverse effects than those of norepinephrine and epinephrine because it does not activate alpha adrenergic receptors. Preparations are IV, IM, and intracardiac injections. Dopamine, also a catecholamine. At low doses, it only acts at the dopamine receptor. At moderate therapeutic dose, it can act at the dopamine and beta-1 receptor. And at very high doses, dopamine will act on alpha-1, beta-1, and dopamine receptors. And I mentioned that dopamine is used in shock to increase cardiac output through the beta-1 receptor and increase renal perfusion through the dopamine receptor. Heart failure, dopamine helps increase cardiac myocardial contractility. The dopamine must be diluted, and it is administered primarily through IV. Dobutamine, also a catecholamine, has specificity for the beta-1 receptors in the heart, and its only indication is in congestive heart failure or chronic heart failure. And it's used in continuous IV infusion in times where heart function is very low. Phenylephrine. Phenylephrine is a non-catecholamine. It has activity only at the alpha-1 receptor, and it is used very commonly as a nasal decongestant. Okay. It also elevates blood pressure when given parenterally. It can dilate the pupils when given in an eye drop, and it can also extend the life of a local anesthetic by delaying absorption. Albuterol, very, very common drug, non-catecholamine. Its receptor activity is at the beta-2 receptor in the lung. It's used therapeutically to treat asthma. It has really minimal adverse effects at therapeutic doses. It'll activate the beta-1 receptor at higher doses, okay? But usually albuterol is inhaled, and so it tends to act exclusively on the beta-2 receptors in the lungs. But with higher doses, the most common adverse effect is tremor and tachycardia. Now, the adrenergic antagonists, these are going to cause direct blockade of adrenergic receptors. And they generally tend to cause reversible blockade. Most adrenergic receptors are more selective than the adrenergic agonists. Most adrenergic antagonists are more selective than the agonists. And we have two major groups. We have the alpha blockers and the beta blockers. So this table, we have the most common alpha blockers and beta blockers. And as you can see, the alpha-1 selective, don't worry about the non-selective, but the alpha-1 selective blockers all end in OSIN or OSIN. The beta blockers all end in LOL, right? Those are the LOLs. And we have several non-selective beta blockers. They're going to block both beta receptors in the heart and the lungs, and selective beta blockers that are only going to act on the lungs. On the heart. Now, even these non-selective beta blockers, the ones that will act on the heart and the lungs, if we're taking the beta blocker, we are looking to block the beta-1 receptor. And any blockade of the beta-2 receptor in the lungs is going to be unintended and a source of side effects. Now, at lower doses of these non-selective drugs, we're going to predominantly bind to the beta-1 receptor and have little binding to beta-2. But generally, these beta-1 selective drugs are going to have fewer side effects because they're going to be limited to the beta-1 receptor in the heart. Now, there are two drugs on this list, on this big list, that of beta blockers that are the most commonly encountered drugs. There's the prototypic beta blocker propranolol, which, as you can see, is nonspecific, and then we have metoprolol, which is specific. Now, one thing to point out, so these two drugs are very commonly seen, propranolol and metoprolol. Now, because metoprolol is beta-1 specific, it is a better choice for patients with either asthma or diabetes, because it cannot act on the beta-2 receptor, so it can't cause constriction of the airways, so good for asthmatics, and it can't act at the beta-2 receptors in the liver, so it can't interfere with blood sugar. Okay? So for asthmatics and diabetics, metoprolol is a better beta blocker than any of the non-selective ones. So why do we use alpha and beta blockers? So alpha blockers are used in primary hypertension or essential hypertension, and it helps lower blood pressure by causing vasodilation. Alpha blockers are also used in benign prostatic hyperplasia, which is an enlargement of the prostate gland in men, which can cause urinary problems, increased frequency of urination, urinary hesitancy, urgency, a sensation of incomplete voiding, and a reduction in the size and force of the urinary system. So alpha receptor blockers help reduce contraction of the smooth muscle in the capsule of the prostate, which is surrounding the urethra, and allows for blocking the alpha-1 receptor allows for easier urination in patients with benign prostatic hyperplasia. So the two major therapeutic applications for alpha blockade is going to be hypertension and BPH. So adverse effects of alpha-1 blockade are going to include orthostatic hypotension, so changes in body position causing a drop in blood pressure and potentially dizziness and increased risk of falls. Reflex tachycardia, where because the alpha-1 blockade drops blood pressure, your body can react by increasing heart rate as a reflex. It can also cause nasal congestion because it causes dilation of blood vessels in the nose, in the sinuses. It can also cause inhibition of ejaculation. And the impotence is reversible, so when the drug is discontinued, it can be reversed. It can also cause sodium retention and increased plasma volume, which is going to be a response by the body to the drop in blood pressure. So the alpha-1 antagonist that we're going to focus on is a drug called prazosin. It's a competitive antagonist. It will cause dilation of arterioles and veins. It also causes relaxation of the smooth muscle in the bladder and prostatic capsule. It's really only approved for hypertension, but in men with hypertension who also happen to have BPH, that prazosin can help with both. But prazosin isn't the drug of choice for patients with primarily just BPH. It can be administered orally. The antihypertensive effects peak at 1 to 3 hours and persist for 10 hours. It's metabolized by the liver, excreted in the bile. A little bit is eliminated in the urine. It has a half-life of 2 to 3 hours. And it has all of the same adverse effects that we mentioned earlier of other alpha-1 antagonists. But prazosin can also have, in a small number of patients, something called a first dose effect. And that's where, when they first take the drug for the first time, they can actually pass out. And they can lose consciousness for about 30 minutes to an hour. And so it's very important that when a patient takes this for the first time, that they're actually in a supine position, that they're laying in bed, just in case that loss of consciousness happens. Now, the alpha-1 antagonist of choice for the treatment of BPH is called tamsulosin. And this drug is a selective alpha-1 blocker, and it has most of its activity in the neck of the bladder and the prostatic capsule. It's approved only for BPH, and adverse effects can include headache, dizziness, abnormal ejection, and ringing of the ears or rhinitis. Nasal congestion or rhinitis. Drug interactions, patients on cimetidine, which is an antacid that blocks histamine, you get potential increase in toxicity with this drug. And hypotensive drugs and other drugs that tend to lower blood pressure, you should not combine because you can end up with a significant drop in blood pressure. So the beta blockers, why do we use the beta blockers? Therapeutic application of beta blockers includes chest pain, angina pectoralis, hypertension, treats hypertension, is going to help treat some of these cardiac dysrhythmias. It's going to be used in myocardial infarction to reduce pain, infarct size, reduce mortality, and it can be used soon after an MI and continued for years after. It can also be used in heart failure, considered standard therapy for chronic heart failure. even though previously beta blockers were avoided in heart failure. So more therapeutic applications of beta blockade, hyperthyroidism. So hyperthyroidism is associated with an increase in sensitivity of the heart to catecholamines. So when a patient has elevated thyroid levels, we can give beta blockers to basically balance out this increased sensitivity. Beta blockers can be used to prevent migraines. It's not really good at treating a migraine that's already happened, but it can decrease the frequency and intensity of migraines. The mechanism is not really well understood, but we know that it can be a good prophylaxis for migraine. And then beta blockers are also sometimes used as an anti-anxiety drug to reduce things like stage fright. Now, it doesn't have a strong anti-anxiety effect, but by reducing symptoms like tachycardia and tremors and sweating, it can help reduce anxiety a little bit. And it's really a temporary fix. So it's taken before people need to speak publicly to prevent stage fright in that one moment. Other therapeutic applications for beta blockers include glaucoma, elevated intraocular pressure. Beta blockers can help reduce the elevated intraocular pressure and help prevent optic nerve injury. Adverse effects of beta-1 blockade, some of them are similar to the alpha blockade, but it includes bradycardia, reduced cardiac output. In a patient with heart failure or undetected risks for heart failure, giving a beta blocker can actually precipitate a worsening of their heart failure. Okay? It can also cause AV heart block. Okay? And so with patients with any existing AV block, beta blockers are going to be absolutely contraindicated. Other adverse effects of AV blockade, if you discontinue a beta blocker abruptly, excuse me, especially with long-term use, you can get rebound excitation. So heart rate can become unstable when you abruptly discontinue it, and it can leave you vulnerable to dysrhythmias and chest pain. So discontinuing beta-1 blockers requires a slow tapering down. Beta blockade can also cause bronchoconstriction, particularly with the nonspecific beta blockers, because of its interaction at the beta-2 receptor. So nonspecific beta blockers we don't want to use with asthmatics, so we choose metoprolol as a better choice for asthmatic patients. And then hypoglycemia from inhibition of glycolysis. If a patient with diabetes requires a beta blocker, a beta-1 specific agent should be chosen, again, like metoprolol. So propranolol is our prototypic beta blocker. It blocks beta-1 receptors. It has some blocking of beta-2 receptors, so it can cause bronchoconstriction. Okay, and then it can also cause some vasoconstriction by blocking beta-2 receptors on certain vessels. And it reduces glycogenolysis, which can reduce blood sugar. Propranolol is very lipid soluble. It readily crosses membranes. It's well absorbed after oral administration. You get a lot of first pass effect through the liver, but it's widely distributed to tissues and the central nervous system. You get hepatic metabolism and excretion through urine. So patients with liver problems or kidney problems, propranolol should be used with care. We use propranolol to treat hypertension, chest pain, myocardial infarction, prevention of migraine, and stage fright. Adverse effects, all the ones that we've already talked about: bradycardia, heart block, heart failure, rebound cardiac excitation, bronchoconstriction, hypoglycemia and diabetes, central nervous system effects like depression. Propranolol should be used with care in patients who are taking calcium channel blockers because calcium channel blockers also lower blood pressure, and insulin because insulin also lowers blood sugar. So general dosing considerations. Effective dosing is a bit challenging, so you can either start small and slowly increase until you get the effect you want, or you can give divided doses are often used. Preparations are going to be oral or IV, and the dosage is really going to be dependent on what you're treating. Okay? Sometimes very small amounts is enough, sometimes larger doses are necessary. Some patients have severe allergies, so we have to be very careful giving propranolol. Diabetes, we want to choose a different beta blocker like metoprolol. In cardiac, respiratory, and psychiatric disorders, we want to be careful using propranolol. We don't want to use it in asthma because of its bronchoconstriction, and we want to be careful because it does cross the blood-brain barrier. It can cause depression. And then we want to avoid it in neonates because it increases lots of risk in that group. Metoprolol is a selective beta-1 blocker. It's a better choice for a variety of patients. It's a second-generation beta blocker. It's not likely to cause bronchoconstriction or hypoglycemia, so it's a preferred beta blocker for asthma and diabetics. But it is also very lipid-soluble. It's well absorbed orally, but extensively metabolized on first pass. And elimination by hepatic metabolism and renal excretion. So metoprolol, if you have liver disease or renal disease, is still going to be used with care. And the same therapeutic uses: hypertension, angina, heart failure, MI. And also same adverse effects, except minimal bronchoconstriction or hypoglycemia. So contraindicated for patients with sinus bradycardia or AV block greater than first degree, which is very similar to propranolol. Caution in patients with heart failure. Only certain patients can be helped with propranolol. Safer than with metoprolol. It's safer than propranolol for patients with asthma and a history of severe allergic reactions. Can be used more safely in patients with diabetes. It will, however, mask some of the signs and symptoms of hypoglycemia. So patients who are diabetic taking metoprolol still need to be careful because some of the early signs of hypoglycemia, like tachycardia and tremors, are going to be much lower in patients taking metoprolol.